3, 2, 1. Please proceed the live.
Good evening, dear doctors. I welcome you all for today's educational event on the occasion of the World Hypertension Day, with a focus on risk factors, measure, control, and live longer. This is truly an historic event for multiple reasons. We have national and international experts present today to share insights on hypertension and its risk factors, along with the unveiling of the heart rate symbol. At the outset, I would like to thank the Cardiological Society of India for this academic session on the occasion of the World Hypertension Day. With this, it is my pleasure and honor to invite and introduce our faculty for today. Sorry. We have two chairpersons today joining us, Dr. M.K. Das sir, who is associated with the B.M. Birla Heart Research Center in Kolkata. Sir is also the immediate national past president of the Cardiological Society of India. Along with Dr. Das, Professor Dr. Robin Chakrabarty will also be chairing the session. Sir is a senior consultant, interventional cardiologist, and electrophysiologist. He is also the senior vice chairman and HOD cardiology services at the Medica Group of Hospitals in Kolkata. We also have as a faculty Dr. P.P. Mohanan sir, who is the director and HOD cardiology at Westford High Tech Hospital in Thrissur, Kerala. Sir is also the president, Cardiological Society of India. Along with this eminent cardiologist from India, we'll have an international faculty who will be joining us, Dr. Peter Todt, who is the director of preventive cardiology at CGH Medical Center in Sterling, Illinois. Dr. Peter Todt is also the president of the American Society of Preventive Cardiology. With that, let me now hand over the session to our chairperson, Dr. Das and Dr. Chakrabarty, please. Sirs, over to you, please.
Yeah. Good evening, everyone. It's a great pleasure to chair the session on a very, very important day today. That is the World Hypertension Day. The raised blood pressure is a global problem. However, over 80% of this burden occurs in the low and middle income countries. BP and cardiovascular mortality are also. Am I audible?
Yeah, sure.
Yeah. BP and cardiovascular mortality are.
Dr. Das sir, if you can please unmute yourself. I believe you went on mute.
So as you know, today is the World Hypertension Day. Some noise is coming from the background.
Adan sir, please.
Raghu?
Yes, sir. Sir, everything is fine, sir. Please go ahead. Please go ahead, sir. Everything is fine.
So today is the World Hypertension Day, and it's a global problem. But 80% or more than that, the burden is there in the low and middle income countries. And overall estimated prevalence for hypertension in India is about 30%, and more so in urban, 33.8% and 27% in rural population. Now, the death rate due to the hypertension itself is also very, very high. Almost 7.6 million deaths per annum worldwide, and 13.5% of the total occurs due to this particular risk factor. And two important diseases, that is stroke and coronary heart disease, are the two important ones. out of so many others. 54% prevalence of stroke and 47% prevalence of coronary artery disease due to the high BP itself. And hypertension is a silent killer. It's very interesting to note that because of the continuum and continuous relationship between BP and cardiovascular deaths, even up to 115 by 75 millimeter mercury of BP, which is much below the target level, that is 140 by 90, is also seen associated with the various target organ diseases like stroke, coronary artery disease, kidney disease, then ophthalmopathy, and all these. And this mortality or morbidity can be actually reduced to a great extent if we are very much aware. If we are aware, then definitely the control will be also better. And my message across the world and also to all the listeners is that our aim should be to lower the BP below 140 by 90 and if possible up to 120 by 80 level so that the target of organ damage does not happen. And along with the high BP, there is another problem, that is the high heart rate problem, which is also very common nowadays because of various risk factors. And it has got its own influence over the increased morbidity and mortality. I'm not going into the detail of the whole scenario. I request our co-chairperson, Dr. Robin Chakraborty, to say more words and highlight some of the other points and then introduce the speakers. Thank you.
Thank you, Dr. Das. Thank you very much. I think we should not waste much time. I think we have already highlighted the theme of World Hypertension Day this year. It is basically accurate measurements of blood pressure, especially for middle and low-income countries, which you rightfully mentioned. Without wasting much time, we got two speakers, and may I request our first speaker, Professor P.P. Mohanan, a very good friend of mine, to start the talk. And then after that, we can have a very special guest speaker from World Heart Federation. Thank you.
Thank you. I hope my slides are visible.
Yes,
absolutely.
visible.
Go ahead. You are visible.
Thank you.
Slides are visible. You are looking gorgeous.
Thank you. President of the American Society of Preventive Cardiology, Dr. Peter Toth, my distinguished chairperson, Hashveer and his team, and my dear members and friends. We know this has been exceptionally challenging time in so many ways, and but then the commitment, the compassion, and the innovation of the healthcare workers are possibly having its effect on the pandemic. And my request on this World Hypertension Day to every one of you healthcare workers will be to continue the same commitment and innovation in managing hypertension, one of the deadliest of the disease. We just heard from Dr. Das, this year's World Hypertension theme, measure your blood pressure, know your number. That has been the theme for the last many years. Control it. And of course, when you control your blood pressure, you definitely will live longer. No questions asked about that. We have now quite a detail on the emphasizing the importance of measuring blood pressure. I will not, it will be superfluous to discuss about this in this crowd, but then everyone should be knowing about the importance of blood pressure measurement. They had the fallacies that one can have. This is important because we know the home blood pressure monitoring is gaining its acceptance much more than the office blood pressure. So measuring blood pressure correctly becomes absolutely important. it's possibly guesstimated that we have about 1.3 billion hypertensives globally, and we in India at least have 234 million hypertensives. And all of us know that it is the most important risk factor for every disease, especially cardiovascular disease. This is one of the largest survey done a couple of years ago, where we collected data from about 180,000 subjects all across India. And this suggested that we have a huge problem of hypertension, very high prevalence. Dr. Bernal mentioned about the prevalence touching on to 30% plus. So much so, 1 in 5 young adults are hypertensives. And that is what an astounding number of hypertensives in our country. The real problem, if you look at the very many data of hypertension prevalence, the prevalence, as we said, is around touching on to 30%. But this is something saddening. Look at the awareness of hypertension. It's just 50%, touching 50%. Now, we pride ourselves, Kerala being the most literate country. Look at the awareness here. It's just 44%. And the treatment and control, look at that. The control of blood pressure is dismal. And this is where all of us has an important role. And interesting, see, we all expected the younger hypertensive to be more knowledgeable and more awareness and treatment and control happen in that sense. But look at that. The younger hypertensives are doing a much more miserable, they have a miserable picture than the older hypertensives in our country, and which again has to be changed. And we have planned tons and tons of guidelines to help us in giving the appropriate dose, whether it is the pharmacological treatment or non-pharmacological treatment. Every guideline helps us, the clinicians, to formulate the individualization of antihypertensive therapy. And that is something which every one of us has to be doing to control this menace of hypertension. Before, and also there are a lot of initiatives. See, the government of India is considering about, thinking about universal screening. This was a program of hypertension control initiative services started in 5 states. Kerala, Punjab, Madhya Pradesh, Telangana, and this was just one of the activities with the idea. The government of just like the members of the World Heart Federation, we want to bring down the percentage of hypertension by 25% by 2025, which is again, it's a tough task, but it's an enviable task. But again, that should be done for the benefits of the people in our country. Before I invite Professor Toth, a couple of slides on since we have the heart rate also playing a big role in hypertension and its management. This is something again which is seen especially in Indians. See, the self blood pressure measurements showed that there is a heightened heart rate response in Indian patients. Indians have a higher resting heart rate than many other people. Something which we have seen, and this has been documented and by a couple of studies, at least published in our own Indian Heart Journal. So it seems that there is a oversympathetic activity in many of the Indian hypertensives. So much so, the prevalence of the sympathetic overactivity touches something like 62%. And this is something I think definitely worth exploring, so that it has its, we know how important is heart rate in heart failure. and hypertension is one of the major cause of heart failure. So it definitely require more attention, and so much so understanding the pathophysiology, managing it also becomes absolutely important. So ladies and gentlemen, my idea of today is to again emphasize the fact and convey you the message of World Hypertension League and the importance of observing World Hypertension Day, in that every one of us should be stressing importance in measuring blood pressure properly, controlling it, and making the Indian population and the world population, let them live long. Thank you very much.
Thank you. Thank you, Mohanan. That was really very brief and precise. That was really very brief and precise. It is really interesting for us to educate and re-educate ourselves about the hypertension. As you said very rightly, that this is very important for us to know right now, that how even today, especially even many countries, even I'm sure even in developed countries, things are completely different. So I'm not sure whether they are exactly the same or not. But anyway, so taking it forward, may I request the next speaker? Mrinal, would you like to introduce the next speaker?
Introduce, I think, Mr.
Peter Toth,
The President of American Association of Preventive Cardiology.
Yeah, so I request Dr. Peter Toth, who is the President of the Preventive Cardiology of America, and he is a very renowned speaker and also worker in the field of hypertension. He has got many publications in the peer-reviewed journals, and it's a great opportunity for all of us that he will be delivering on a very important subject, that is hypertension and implication of heart rate on this occasion of World Hypertension Day. The stage is yours, Mr. Dr. Toth.
Well, thank you so much. And I thank all the attendees, the leadership, and I also thank the Cardiological Society of India for inviting me. I was initially told that I would have 30 minutes, but I was told just a few minutes ago that I had 13. So we're going to move along here. And the question I have is, will the tech put my slides up, or do we need to put our slides up?
Sir, you will need to put up your slides.
Oh, okay.
Yeah. Will you be able to do that?
Yes.
Yeah.
Here we go. Okay, so hypertension and associated sympathetic overdrive. As has already been pointed.
We don't see your slides, sir.
Oh, okay. Hold on one sec.
Yeah. You share your screen.
the green button, share screen button.
Yes, I have it. Here we go. Share screen. Do you see it now?
Yes.
Okay. So
And now you go to show slide. Go to the show so that the whole screen will be full of the matter. Yeah, go to the show. So this one, the one right in the corner. Exactly. Click on that. Click on that. There you
good?
Go.
Okay.
Excellent.
So as has already been alluded to, hypertension is often associated with sympathetic overdrive in Indian people. And this, of course, is associated with increased pulse pressure. And it poses a challenge because not only does the hypertension increase risk for adverse cardiovascular events, but there's no question that high pulse rate is also associated with adverse cardiovascular events, including increased risk for MI stroke, as well as premature mortality. So what do we do? Well, we've already talked about hypertension, but now the new guidelines tell us that anything over 130 over 80 is actually hypertension, stage 1 hypertension. And then the severity of the hypertension, of course, increases as the blood pressure goes up. But now it does behoove us to try to decrease blood pressure to less than 130/80 in our patients who manifest hypertension. So we're going to focus very specifically on beta blockade because we know that beta blockade is very important in patients with sympathetic overdrive, because the entire etiology of sympathetic overdrive depends on increased central release of catecholamines. And of course, catecholamines play an extremely important role in overall cardiovascular function. So what do the new guidelines tell us about how to situate a beta blocker? Well, if our goal is treating someone with ischemic heart disease that's symptomatic, of course, beta blockers play an extremely important role because they reduce afterload, they decrease rates of left ventricular oxygen consumption. And in patients with stable ischemic heart disease, this is a very crucial goal because now with reduced left ventricular oxygen demands, the heart will contract better and is less vulnerable to ischemic episodes. So the guidelines tell us that in patients with stable ischemic heart disease, start with beta blockers that have established evidence for their use. And this would include drugs such as carvedilol, metoprolol, bisoprolol, and timolol. Now, how about for patients with risk for developing heart failure because of left ventricular hypertrophy, septal hypertrophy? And again, beta blockade is also recommended in this situation. And if you have patients who have heart failure with reduced left ventricular ejection fraction, of course, beta blockade is recommended because they're living in a catecholinergic soup with increased, of course, angiotensin, increased aldosterone, but the increased catecholamines are increasing risk not only for increased afterload, increased rates of left ventricular oxygen consumption, but they also predispose the patient to markedly increased pulse rates and potentially malignant and lethal arrhythmias. Okay, so understanding sympathetic overdrive. This is actually very complicated, and it has a very complex pathophysiology. And the more complex the pathophysiology, of course, the broader the implications for cardiovascular morbidity and mortality. So what is sympathetic overdrive? Well, basically, it's a part of the fight or flight reflex because it does involve a sudden large secretion of catecholamines from the central nervous system. But this can also be chronic, which is exactly what we see in patients who have hypertension and high pulse rates. So what happens? Bottom line is this can relax the bronchial passages because you want to increase oxygen availability. You accelerate heart rate because you want to be able to mobilize quickly and get away. It also inhibits gastric peristalsis secretion, stimulates glucose production and release, which is bad, especially if the patient is insulin resistant. And then not only is there central sympathetic outflow, but there is also increased adrenaline and noradrenaline, which is acting locally via parasympathetic ganglia. Okay, so if there's chronic sympathetic activation, where's this coming from? And actually, one of the most important etiologies for this is metabolic syndrome, insulin resistance. As the brain becomes insulin resistant, it actually is less responsive to many forms of communication from visceral organs. And there is a slow increase in nonspecific secretion of catecholamines. And this gives rise to the many features we talked about. Sympathetic overdrive tends to be triggered by arterial baroreceptor impairment, which is also possible in the setting of insulin resistance, but also increased production of angiotensin II by the kidney, as well as a hyperleptinemia, because if the patient is insulin resistant, they also tend to be leptin resistant, and hence there is less capacity for the thalamus to communicate satiety and other forms of interaction with the gastrointestinal tract. So with sympathetic overactivity, what do we see? There tends to be arteriolar constriction, which is going to reduce muscle blood flow. There's increased oxygen consumption, increased risk for ventricular arrhythmias. And when you couple this with the insulin resistance, the obesity, this also now swirls with dyslipidemia, heightened inflammatory tone. You now set the stage for endothelial dysfunction. You set the stage for a loss of left ventricular compliance and distensibility because of cardiomyopathy. You have left ventricular systolic dysfunction, atherogenesis, and also there can be left ventricular myocyte apoptosis. And then this becomes replaced with increases in collagen deposition and fibroblast deposition. All told, this increases risk not only for coronary events, but also for sudden death and heart failure. So as we see here, sympathetic nervous activity, when it's heightened, leads to increased neural release of norepinephrine. And now what else happens mechanically? Well, there's increased pulsatile stress on the arteries. This can accelerate atherogenesis. And if there's increased pulsatile stress on the arteries, there can be increased risk for torsion. There can be increased risk for sudden changes in the constriction of the vessel leading to plaque rupture. And of course, there's increased risk for cardiac ischemia. So there is increased heart rate, reduced heart rate variability, and the beta blockers are going to be increasing left ventricular contractility for a while. But with increased afterload, you're also going to observe accelerated left ventricular hypertrophy, loss of distensibility, and the like. And so ultimately, that augmented contractility is short-lived and ultimately leads to diastolic dysfunction. And to couple this now with this poison soup, we see increased renin release, angiotensin release, blood pressure is rising, of course, because now you have higher levels of catecholamines, renin, angiotensin, and with the left ventricular hypertrophy and no relief in afterload, the patient is predisposed to heart failure. So this is a very toxic soup, very dangerous. If heightened pulse rate is recognized in a patient, even with borderline hypertension, really aggressive intervention has to be made because this will only get worse. And this is a very important warning sign that the patient has many forms of metabolic dysfunction with broad spectrum pathophysiologic consequences. And we see here in this flow chart that when there is sympathetic nervous system activation with high pulse rate, an enormous number of phenomena occur, all of which are injurious. And we've already talked about the RAS axis activation, reduction in myocardial reserve because of increases in rates of left ventricular oxygen consumption. There's reduced myocyte contractility. And with high heart rate, you're going to have less time in diastole. There will be less time for replenishing coronary perfusion, reduced coronary blood flow. There can be increased electrolyte abnormalities because of the RAS axis activation. There's progressive cardiac remodeling, particularly in the left ventricle, the left atrium. There's cytokine activation. And of course, you see here increases in vasoconstriction, reduced responses to exercise, ischemia, increased arrhythmia risk, cardiac dysfunction, predisposing to heart failure and sudden death. It's not clear to me how much time I still have left, but if I have perhaps 2 more minutes, that would be good. And we know that in the Indian subcontinent, diabetes, insulin resistance, prediabetes, metabolic syndrome, highly prevalent. And we see here that for patients with type 2 diabetes who are insulin resistant, who produce excess amounts of insulin, this also correlates with increases in norepinephrine release, and this toxic soup results. Just being insulin resistant can predispose to hypertension and high pulse rates and activate all of these various pathophysiologic phenomena. And so when we look at patients with essential hypertension plus diabetes, just essential hypertension, diabetes, or people who are normotensive, you see that sympathetic activity is highest in the ones who have both the essential hypertension and the diabetes. The diabetics come next, followed by the essential hypertensives, followed by the normal tensives. So very clearly, based on these data out of Framingham, insulin resistance, diabetes, hypertension, all increase central catecholaminergic output. This can also be exacerbated by acute mental stress. In the setting of acute mental stress, there can be increased corticotropin releasing hormone. There's an increase in endothelin-1 and an increase in cell adhesion molecule expression because of endothelial dysfunction. The endothelin-1, of course, is a very potent vasoconstrictor. An increase in cell adhesion, of course, potentiates intravascular inflammation. You're promoting the influx of inflammatory white cells. This leads to extensive remodeling, not only in the arterial wall, but also potentially in the myocardium in the setting. And then, of course, there can be an increase in cortisol, which results in reduced nitric oxide bioavailability, an increase in the production of reactive oxygen species, a rise in blood glucose because of increased hepatic gluconeogenesis and glycogenolysis. Free fatty acids are increasing because in this setting, cortisol is promoting nonspecific triglyceride hydrolysis within visceral adipose tissue. The endothelin-1 levels rise and inflammation increases. Hence, in this setting, it does become important to use beta blockers. And beta blockers, of course, can help blunt this injurious impact of this hypercatecholaminergic state. And beta blockers have clearly shown great benefit in being able to help manage hypertension in the setting of sympathetic overdrive, but also in helping to reduce risk of cardiovascular morbidity mortality in the setting of heart failure in patients with stable ischemic heart disease, in patients who are post-MI and the like. All of you know this very well. So bottom line is, does obesity increase risk for increased sympathetic nervous activity? Yes, because it correlates with insulin resistance. And so when you look here at lean, peripherally obese, centrally obese patients, the greater the visceral adiposity, the higher the likelihood that the patient will have insulin-resistant adipose tissue, and the higher the likelihood that the patient will have some degree of increased sympathetic overdrive. And similarly with smoking, the nicotine stimulates sympathetic ganglia, promotes the release of catecholamines. This, of course, increases afterload, peripheral resistance, heart rate, and blood pressure. Okay, and so let me just show one more slide because I think this drives home the point that my colleague made earlier, that this is a very dangerous physiologic state. If you look here at these data, look at high heart rate, uncontrolled blood pressure, and high heart rate blood pressure controlled. My goodness, look, there's really, they're very tight together, and there is a very high mortality rate here. And if you look at low heart rate, blood pressure uncontrolled, blood pressure controlled, those patients have a 53% difference in the incidence of endpoints. So bringing the heart rate under control coupled with blood pressure control clearly is an important physiologic target and helps to keep people out of harm's way. And I believe with that, I'm just going to conclude with one last slide, looking at risk of mortality in young men. If you look here at heart rate above 100, 80 to 100, 60 to 80, look at the incidence of coronary heart disease, cardiovascular disease, all-cause mortality. As heart rate increases, all of these endpoints steadily rise. And so I agree with my colleagues of the CSI that high heart rate is an issue in India. High heart rate is a bad predictive risk factor, and it is something that we can easily address through lifestyle modification and beta blockade, and hopefully ameliorate much of the excess morbidity and mortality associated with this. And with that, I want to thank you very much.
Thank you, Dr. Todd. It's a great talk. I think we can take some questions. Mrinal, what do you think?
Yes.
And then we can have some message for the audience.
Just before that, may we invite some comment from Dr. Debabrata Rai, who is the Honorary General Secretary of Cardiological Society
Sure.
of India.
Perfect.
Dr. Debabrata Rai.
Yeah, Dr. Roth, that has been a real illuminating lecture, and also we learned a lot from deliberation of our president, Dr. Mohanan. And what I believe that there is a real gap between awareness and treatment of hypertension, and a fact that has been borne out by a number of studies. So I'd request this expert panel to focus on some ways as to how this breach can be solved. This gap can be breached.
Yeah, thank you,
Would
Dr.
may-
Rai. Yes, Dr.
Dr.
Toth,
Toth.
would you respond?
Yes, I was hoping my Indian colleagues would respond first, but let me just say that Professor Roy is quite correct that there is a profound underachievement of blood pressure targets worldwide. This is everywhere, including the US. And it applies to lipids, diabetes, everything. And so there's a real disconnect between what guidelines state and what is being achieved in the real world. And I think it's very clear that when you identify hypertension in someone, depending upon the severity, you really have to make sure that they understand what's going on, what the implications of the high blood pressure are, and why it's so important to get the blood pressure down in order to derive long-term health benefit, like reducing risk for MI, stroke, and mortality. If they don't understand this, they're not going to follow through. And we know that long-term adherence, especially with a drug like a beta blocker, which I talked about just now, tends to be very low, because if a patient is feeling fatigued or they feel that they are slower on a beta blocker, they don't want to take it. But if they understand why they're on it, then the long-term adherence tends to be much better. And if they're seeing success in getting their blood pressure to goal and their pulses down, they're also much more likely to remain adherent.
Dr. Roy, if I have to interject, because the government of India has been trying, we have seen the data from India. Even the last 2018 data of NHANES, the American data shows the control rate is diminishing, surprising. See, so it's a real problem, as Professor Toth mentioned. So there are three ways of sort of addressing the issue. One is the universal screening, and which is the every government. You remember the blood pressure recording at the barber shops in the United States? So opportunistic screening is the best way it is one way of a universal screening. And of course, the second way, as you know, is the providing the medication. 80% of we in India, it is out-of-pocket expenditure. So if somehow we can improve the drug deliveries and also involve not the doctors, the paramedics, the ASHA workers, that's what the government also is trying to do. The ICMR has the multiple projects involving the ASHA workers, trying to improve the adherence of medication and improving the blood pressure control. And of course, third will be what our society also is doing, teaching everyone, including the doctors, the public, about the importance of hypertension, the risk involved in the hypertension. I have a question to Dr. Toth. Now, the importance of heart rate, all of us agree heart rate is one of the prognostic factors, but will there be, I think we may need more research in that, because if we can identify a youngster with an elevated heart rate, is this the guy who will develop hypertension in middle age? Is there any data related to that?
Yeah, see, now, when you say a young guy, how old are you thinking?
Maybe 18, 20s, in his 20s.
Yeah. So there, I think the question is, are they physically fit? Are they a little bit tachycardic just because they're unfit and they're playing too many video games? Do they have early onset insulin resistance, which of course would portend poorly for that patient long term? So there are many factors. And I am not aware that looking at pulse rates in adolescents is very predictive of hypertension later in life. But what we do know is that in young and middle-aged adults, most certainly increased heart rates are a bad prognostic indicator. They do correlate with heightened risk for hypertension and for heightened risk for cardiovascular morbidity and mortality.
Mrinal, you have something in the chat box.
I think what we observed during our day-to-day practice, that the young hypertensives, they definitely are found to have increased heart rate as compared to the elderly hypertensives. So that is our observation, but we have not created any data for that, but that is there. And that is why we always advise the various markers for sympathetic drive, like catecholamine estimation and this BMA and all in this young group of patients. Even if they are not having any pheochromocytoma or this kind of diseases, specific diseases, but definitely a high heart rate problem is a problem in the young. And after saying this, I have one point to actually make regarding the lack of awareness and lack of control, which is happening all throughout the world, not only in India or low income country or anywhere, everywhere. It is seen that the control as well as the awareness, especially the control, is not appropriate because of one fact, that we are given a number that is, say, for example, 145 by 95 or 150 by 90 or even 135 by 85. Now, after 3 months or 6 months, the patient comes back and we get that number to say, for example, in case of 145 by 95, down to 140 by 90 or 135 by 85. So over 3 months, we didn't know what has happened in the blood pressure level all across the 3 months or 90 days. Now, one of the postulations or rather theories I have actually put forward, which has been published in last year's in European Heart Journal, that is the sigma value of the surge of BP, that we can estimate that actually the surge of BP occurring throughout 24 hours or even to 48 hours. And that surge, if we just sum it, then the number, overall number becomes very big. And that time, possibly the fear of the target organ damage becomes more prominent, and thereby the physicians or even the patients, they are bound to take care of that high number rather than taking care of, say, 145 by 95. Oh, 145 by 95, it's nothing. If we just exercise or if we take a little bit of medicine regularly or irregularly, then that will control, but that does not happen. And that is why I think it's a high time that we take care of the surge of the BPs over a period of time. Now, my third point is to Dr. Toth again, and also to the panelists, that we were using the beta blockers quite frequently in our early days in late 80s and early 90s. But suddenly the beta blockers were rather disregarded, and they were coming down in the lower part of the algorithm. Now, I think that was a sort of wrong approach by putting the beta blocker in the lower part of the algorithm. Beta blocker has got its role, especially with the advent of the newer beta blockers, which have got vasodilating activities like bisoprolol, then metoprolol, nebivolol, and all. And I would like the opinion of Peter regarding this, why it was downgraded.
Yeah, that's a very interesting question because when you look at the evolution of the various guidelines, there was a great deal of flux between calcium channel blockers, beta blockers, ACE inhibitors, ARBs, and the like. And I agree with you, Professor Kantidas, that it was a mistake to sort of downplay beta blockers, mostly because of issues of fatigue or bradycardia, which was overstated. Clearly, the guidelines are very clear about where to use beta blockers as first or second line agents, such as in patients with stable ischemic heart disease, patients who are post-MI, patients who have left ventricular systolic dysfunction, heart failure, preserved ejection fraction, and the like. So I think it's gotten better. And certainly people have their favorite beta blockers. Beta blockers have excellent evidence. I mean, bisoprolol, carvedilol, timolol, they have excellent evidence for their use. And I think people need to take another look at some of those classic trials, which really established the efficacy of beta blockade in the various settings of cardiovascular disease and hypertension.
Thank you.
Right, I think
one question.
we got some questions in chat box, but before that, a quick question to both Professor Mohanan and Dr. Toth. One is, as we are all aware, that one the major constraint of blood pressure control or blood pressure treatment is the compliance, because largely the patients are asymptomatic, and even if they take tablet, they feel well, they feel better, but they can't really make a huge lot of difference between before medication and after medication, especially if the blood pressure is, let us say, systolic is more than 160, something like that, 164/94. They will not feel a lot of difference. So because of that is the reason why compliance failure. Second is, do you reckon that ambulatory blood pressure monitoring may be extremely helpful, as Dr. Das pointed out? That is question one. Second is how we can educate our community about importance of blood pressure in order to prevent heart disease, stroke, renal disease. What would be the take-home message? After taking these two points, we got some questions in chat box. We can probably go through these questions, and one of you can answer maybe alternatively, and so the audience can be happy with the answers.
I would like my Indian colleagues to go first.
Okay, right. Right. See, as I was just mentioning, Robin, the government of India has come out with some of these proposals. Then now the ICHI model was one of them. So utilizing the ASHA workers was one of the basically now we have India is a country with maybe 100 million or Facebook post, WhatsApp group, that group, this group, and your soft phones. So basically, if you can give them, the apps are plenty available. People have validated that. If you are also aware of the decision support systems available, and that has been implemented at least in 5 studies in India, in Simla, in areas where you cannot even the paucity of doctors, where the paramedics were given these systems even to modify the treatment. The decision support system algorithms and pathways were given, and they were doing that, and that could improve the control of blood pressure. Of course, the second important, most important point will be, as I said, the availability of the drugs. That also is now. Now we have ACE inhibitor, enalapril, and amlodipines are available in most of the primary health centers. So yes, the NCT division is very active in that. I think the third point is where the society also has to really work hard now, educating even our doctors, general practitioners, family physicians, and of course patients about the importance of blood pressure and the havoc it can create in their life.
Thank you.
Over to you, Toth.
Yeah, I agree with absolutely everything that Professor Mohanan said, but I'm going to go back to my other point which was making sure that there's adequate patient education so that they understand why blood pressure elevations and high pulse rates are devastating to their health, why it's so important that they remain on their medication, and what the benefits are long-term in terms of reducing risk for cardiovascular morbidity and mortality. I think that goes a long way toward also improving long-term compliance.
Thank you. Can you just go through the questions? First question, Dr. Hawk from Patna, a state in India. What should be the ideal heart rate above which there is increased risk of cardiac events, including heart failure in a hypertensive patients? Dr. Toth.
So,
One of the slides showed that.
yeah, I mean, bottom line is, I think worldwide, a pulse of 60 to 80 is regarded as normal. So if someone is persistently drifting into the 84 to 86 range, and then they go to 90, I would definitely call that they're going into the abnormal range. Now, obviously, if people walk around the block, they're engaged in physical exercise, the pulse rate will go up. But I think 60 to 80 is normal. And if it starts extending into the upper 80s, lower 90s, that patient is experiencing increased sympathetic activation. And I think action needs to be taken first and foremost, if the blood pressure is borderline, at minimum lifestyle modification, because probably what's underlying this is at least some degree of insulin resistance, especially in a younger patient. And then if there are more complex issues, then obviously none of this is a one-size-fits-all situation, and we have to dig a little deeper. But that would be my response to that.
Dr. Mohanan, what is the best shot of beta blocker? Or maybe Dr. Toth again, sort of at what point do you commence beta blocker right from the beginning? Or when you commence beta blocker once the heart rate goes beyond 84, 85? What is your way of looking at it?
Yeah, so if I believe that a patient is manifesting insulin resistance, their pulse is clearly increasing as a function of time, I think a beta blocker is a very smart choice. And if they need a second agent, I'll probably go for I would go with an ACE inhibitor, because we know that when catecholamines increase, angiotensin II and aldosterone levels also increase, because the sympathetic activation also activates the RAS axis in the kidney. So I think a beta blocker and an ACE inhibitor, not only in the setting of stable ischemic heart disease, post-MI, heart failure, et cetera, but also in hypertension with increased heart rate, I think that combination is well validated.
Great. Dr. Mohanan.
I mean, we should also realize, I mean, the shortest acting, we don't have too many choices here, right? We have only metoprolol tartrate as a shorter acting beta blocker. But then we should also realize the fact, now we are talking, as Professor Toth was saying, in compelling indications, it's much more easier to use. In a common garden variety of hypertension, the guidelines are also important. So your usage should be basically guideline based, but you may find a situation where the resting heart rate and vis-a-vis the sympathetic activity will be higher, wherein you can definitely use the beta blockers. But then, mind you, yeah.
There's always
the next question. We are a little running short of time. Quickly, anyone from the panel? There's a good question. Can heartburn and reflux be related to hypertension? Anyone from the panel? Mrinal?
I think let Dr. Roth will seek the opinion of Dr. Toth.
Okay, Dr. Toth.
Well, I suppose, I mean, the vagus nerve has significant control over the intensity of lower esophageal sphincter closure. So if there's increased central sympathetic outflow in that situation, perhaps. But I don't think hypertension per se necessarily correlates with risk of gastroesophageal reflux.
The next question is a little tricky. During COVID era, what would be the ideal way of measurement of blood pressure like measurement of pulse, saturation. That's what you do with the oximeter, pulse oximeter. Can we do measurement of blood pressure by monitor? Is it
That's
appropriate?
better, Anna. That tells it's a fact that we better avoid. Robin, I missed one of the points you brought in about the ABPM's use.
Sure.
But then in a country like ours, I think much more easier is stick with home blood pressure monitoring, even though ABPM has its advantage of blood pressure variability, as Das mentioned about the quantum effect and all those things. But right now, office blood pressure and home blood pressure will be more suitable.
Yeah, I'm sure for a huge population, it may not be appropriate. Any role of ibuprofen for the treatment of tachycardia?
I
don't think
monitoring of blood pressure with the the electronic method is quite acceptable and validated, especially in sprint trial. The automatic blood pressure monitoring and measurements were done. So it's quite validated. So, and it is being right now practiced during the corona time, when all the patients are undergoing blood pressure measurements with the automated blood pressure machine.
Sure.
So that's
can you take this question quickly, Mrinal? Yes. Any role of ibuprofen for tachycardia? I think ibuprofen is a different indication, doesn't fit here in hypertension. This is a very straightforward answer. There's another very interesting question. The tuberculosis, pulmonary, extrapulmonary can cause tachycardia. What is the relationship with hypertension? I think when Peter Toth talks about tachycardia and hypertension, probably we should exclude other causes of tachycardia like fever, thyrotoxicosis, any other condition that must be excluded. Am I correct, Dr. Toth?
Absolutely.
So, Dr. Deepak, next question is, does insulin has any role in glucose metabolism in brain cells? I think this is not a question of on World Hypertension Day. I don't know. Dr. Mohan, would you like to take it up?
Insulin has an absolute role in glucose metabolism, whether it is brain or heart or wherever. What is the doctor about it?
Right. I think probably we're just finishing it. Dr. Das, can you like to conclude? And Debabrata, you want to conclude?
Professor Chakraborty, can I, and you and all the other faculties, can I request you to give a quick comment, because there is a significant percentage of the general population who are attending today's seminar. So any message on this World Hypertension Day for them from each of you?
Okay, Dr. Das first. Dr. Das first.
I think I convey my regards and thanks to all the participants, including Dr. Mohanan and Dr. Peter. They have excellently presented their deliberations, and especially Dr. Peter has presented uniquely the correlation between the sympathetic system and multi-metabolic problems associated with hypertension, high heart rate problem, which is associated with hypertension. So beta blocker gets its importance even in hypertension with tachycardia or high heart rate, not even defined as tachycardia classically. So that is very, very important message he has conveyed to all the listeners. Now, my overall comment will be regarding the high blood pressure control and awareness on this particular day, that as per the Indian guideline, 140/90 is the target blood pressure. We must bring down the blood pressure level below 140/90. And if possible, we should bring it down to up to 120/80, because it has been found by many studies that even at 120/80 level, there may be some catastrophe or there may be some target organ damage. So that is why when it is feasible or when there are no symptoms of controlling the blood pressure up to 120/80 level, we should try by titrating the doses appropriately to bring down the blood pressure even below 140/90. And if we do that, then it will be a human job for the whole country and for the whole globe, that the control of blood pressure is leading to a very remarkable transition to less number of strokes and less number of coronary artery disease and less number of CKD or chronic kidney disease.
A single message from my side is, that 17th May every year is just not World Hypertension Day. It is a recall of your blood pressure measurement. So this is a day when you should be aware and you should try to measure your own blood pressure and to ensure that the members of your family's blood pressures are being known to everybody. And in case you find it to be elevated, at least for more than 2 or 3 occasions, you should seek for medical doctor's opinion. That would be a kind of my single message. And measurement is important. And 17th May every year is a recall day of high blood pressure. May I just request Dr. Devapati Roy to conclude the session?
Yeah, Professor Mohanan, please.
I mean, I think my talk was the message, but then I will just say again that the month of May, not the 17th May alone. Generally, the World Hypertension League observe month of May as the measurement month. This time, surprisingly, because of the COVID, they have extended from 1st of May to 30th of November. So concentrate on measurement and control.
Professor Todd, any message for the general public?
Yes, I think as World Hypertension Day teaches us about the prevalence and the dangers of hypertension, I think we all need to resolve to make sure that we treat this aggressively in our patients and help them understand what hypertension does to their long-term health and why long-term adherence to medication is so important. This is a very easily treatable disease with huge impact. And obviously, all of us, me, everybody in the world, we all have to do a better job of getting our patients' blood pressure under control.
Thank you, sir. So I think the need of the hour is to put
sir, just talking from the back end.
Now over to Ashvi.
Sir, thank you so much, Dr. Roy, and the panelists. Sir, we were talking a lot about the heartbeats, the management of hypertension, and we have had experts who manage heartbeats to save life. We also have a young talent who creates musical beats to celebrate life. May I please invite our special artist on the stage to share his musical journey with us for a minute, please.
Namaskar. This is Shubhodra Kolan from Kolkata, India. I'm going to start my performance, but before that, I'm going to say a word or two.
Yeah.
Well, music is all about melody and not about noise. And beats are all about harmony and not just about the bass. So I'll dedicate, as a young musician, Beats Forever to all the young Indian hearts out there. Let's all move from chaos to peace. Slow down is the mantra.
Thank you so much, Subrata. Thank you so much, Subrata Kalyan, for those amazing beats that you have shared with everyone. From these beats,
Namaskar.
coming back to the beat of life, coming back to the heart rate, which has been emphasized as an important risk factor if it is increased, and looking at the role of sympathetic overdrive in our patients. May I please invite Dr. P.P. Mohanan, sir, to now unveil the logo for the heart rate symbol. Sir, before we unveil the logo, please say a few words on it, please, sir.
Thank you. We just listened to Professor talk about the importance of the heart rate. Absolutely, the resting heart rate is an indicator of cardiovascular health and an important prognostic index for cardiovascular mortality and even total mortality. So I think in the years to come, of course, it is an area to be researched extensively, but I'm sure that this will open up ways for reducing the cardiovascular burden and also cardiovascular mortality. So with these words, I have the absolute pleasure in unveiling this logo, which I am told is a handiwork of about 5,200 doctors all across India, and voted this particular logo. And this is being done for the first time in the world. Wow. Thank you. And I have the rare opportunity to unveil it. Thank you. What do I do?
Sir, Raghu will take it over. Raghu, over to you, please.
India, the land of 1.38 billion beating hearts, where 1 in 5 young Indians have high blood pressure. We Indians also have high resting heart rate of 80 beats per minute. Need is to bring about greater awareness, encourage better measurement, ensure effective management for blood pressure and heart rate. To make this dream come true, in February 2021, the International Heart Month, we embarked on a journey across 60 cities of India, where 5,200 clinicians from the heart voted for one universal symbol of heart rate. A small step to increase the awareness of role of heart rate in the management of CAD as part of RACE on the occasion of the World Hypertension Day to combat the low awareness rates worldwide. Let's together make a difference. Presenting the world's first heart rate symbol. Measure blood pressure accurately. Control it. Live long. India.
Good. It looks nice.
That's very clever. Very clever.
Very nice. Very nice.
Thank you so much, sir, for this excellent educational initiative that we have. We had 2 important lectures from Dr. Mohanan sir and Dr. Peter taught, highlighting the importance of hypertension, highlighting the importance of risk factors which are associated with the excellent panel, our chairpersons, Dr. Das, Dr. Chakrabarti, and Dr. Roy, for adding their clinical experience and expertise during the discussion. And with that, I hope that everyone is keeping safe. Please be safe in this difficult times that we are facing, and we hopefully will come out of this very soon. I hand it back to our Dr. Roy and Dr. Das sir for the closure.
Dr. Dash, please. Any concluding remarks?
Thanks everyone. Thanks for the symbol that is actually presented to us today on this World Hypertension Day. And thanks to everyone who participated in today's program.
Thank you. Thank you very much.
Over to Dr. Rai.
Thank you. Thank you, Dr. Toth.
So,
Thank you, Dr. Toth. I thank Dr.
Thank you. Thank you, everybody. Thank you.
Thank you. Thank you. Thank you.
Thank you so much, sir.
Yeah.
Good night.
I believe it has been a very illuminating seminar, and it has, I believe, it has benefited all the participants, with doctors and even the general public, representatives of the general public, who made some time of their busy schedule to attend this program. The need of the hour, as has been already stressed, to translate awareness of about hypertension to proper control of hypertension. And this is a stupendous task. And I believe Cardiological Society of India, under the able leadership of Dr. P.P. Mohanan, will act in a collective way to bring about this fundamental change in approach towards hypertension among Indians. And lastly, I would like to remind you all that CSI has brought out an app called CSI Healthy Heart app that can be downloaded. And I think this is going to help your patients and all the general population about controlling not only their blood pressure, but also other risk factors. I'd like to thank Mr. Harshveer from Merck and Raghu from Medcom for making this wonderful program possible. And I promise all our members to bring many such programs in near future. Thank you all.
Thank you very much.
Thank you.
It's a great show. Thank you.
Thank you.
Take care of yourself.
Thank you so much. Good night and good day to Dr. Todd, please.
Thank you.